All right. So I just want to make one quick announcement that this is the start of the radiology section in diagnostic methods. We have Dr. Schreibman here today who will be with us for a few weeks, and we have a lot of other great radiologists coming in over the course of the next few weeks to talk about the radiology aspects of kind of what we're learning. For the most part, we really try to overlap this. So I know coming up soon you guys will have chest x-ray and kind of how to read those to help. The one thing I do want to emphasize again is that these lectures get tested separately. While they may help you in your clin med and diagnostics and stuff, this stuff that's on these lectures gets tested separately and not in your big 3 exams that you normally have on Mondays. Okay, so I just don't want you to be confused about that. Otherwise, we'll let Dr. Schreibman go. He has awesome PowerPoints. He puts the rest of us to shame. So I look forward to seeing them all this semester.
Well, thank you so much. I'm very excited to be back here at the start of this, I'm going to call it the spring radiology course, even though it's not spring-like at all out there. Yeah, so basically we have a whole series of lectures over the next couple of months. We'll be meeting almost every Monday, Wednesday, and Friday. This one got scheduled early, but the rest are all going to be at the 11 to 11:50 time slot. I'll be giving you several, and I'm bringing in other faculty to give them as well. I'm going to try to keep at least a day or two ahead with Learn at UW. I'm still collecting everybody's handouts. There's stuff up there that's like from last year, so if you want to read ahead, you can, but I'm going to, I have the handout for today and Friday up there, but I don't have the rest of them up there, so we'll get that all figured out. I assume everybody can get to that Learn at UW. They keep on changing it, so I have to keep on learning how to post material. So this next series of lectures is we're going to focus on the upper extremity. We're going to do the hand today, which is kind of a nice general talk. We're going to do the wrist on Friday, which is a more complex talk. Your homework assignment for tonight, well, before Friday, is I'd like you to review the anatomy of the carpal bones, the bones of the wrist. I know it's confusing. In the lecture, I will go through them one at a time. You can actually download the lecture, either the PowerPoint or the PDF right now to review that anatomy, but it would help you to understand what I'm talking about on Friday if you actually can identify the bones, but we'll go through that all as well. But I really like starting with this first talk on the hand. The topics we're going to cover today, I'm going to start a little bit about history of hand imaging, and then I'm going to talk about the indications of why you would image the hand. And I'm kind of separating the hand from the wrist, because from a radiology standpoint, these are really very different things. Matter of fact, we're going to go through some terminology, including what's the difference between a hand and a wrist, why we talk about radial and ulnar rather than medial lateral. I'm going to tell you how to talk about fingers, and then we're going to talk about some radiographs, how we shoot radiographs of the hand, and then we're going to go through some of the fractures that are unique to the hand, the mallet fracture, the boxer's fracture, the gamekeeper's fracture, the Bennett fracture, and we're going to finish up with what to order when. And the big difference you're going to see between all of these lectures and the ones I gave you last summer is last summer was very general. We talked about the bones generically, the joints generically. I hope it stops doing that. This lecture, all the rest of the lectures, we're going to focus on each joint individually. And the thing to appreciate is each joint is different, each bone is different, and that's what makes it so hard. They're all very different. But regarding the hand, the thing I like about the hand is that the hand is very accessible. It's really the one place on the body where it's socially acceptable to touch another person. So whether you're holding hands, whether you're shaking hands or just holding hands, the hand is very handy. And a matter of fact, because the hand is so handy, we have literally been imaging the hand since day one. This is the very first radiograph of Röntgen's wife's hand, December 22nd, 1895. It was Röntgen who called these X-rays because he just said there's some unknown quantity, we're going to call them X, just like when I'm doing math with Marty, he always calls the variable X because that's the only one he understands, X. So X-rays, some unknown quantity. The exposure time for this hand radiograph was 15 minutes, and it's actually not a bad image. You can see quite a bit of detail here, but 15 minutes is a long time. Any idea how long it takes to do a hand radiograph nowadays? Yep.
2 seconds.
2 seconds would actually be a very long time. We're down into 5 milliseconds, 5/1000th of a second. That's how efficient we are of capturing images. Very, very quick. This is a reconstruction of the very first demonstration. This is Röntgen demonstrating his new X-rays at the Würzburg Physical Medical Society in 1896. And, of course, he's imaging the hand, because the hand is handy. And this is the hand of the president of the society, Albert von Kolliker. And von Kolliker was so impressed with all of this that he proposed these rays not be called X-rays, but Röntgen rays in honor of Röntgen. And to this day, we still use this term. For example, I'm a member of the American Röntgen Ray Society. This date is interesting, January 23rd, 1896. This was when the world first learned about X-rays. And it didn't take long until we were being used clinically. February 3rd, 1896, literally weeks after Röntgen's discovery, this was the first clinical use of X-rays in the world. This was all set up by a photographer named Howard Landgill. Landgill had read about Röntgen in the newspaper. This was a worldwide phenomenon. And he said, I bet we could do this. He had photographic plates, because he was a photographer, and he says, I just need some X-ray tubes. So he called the Dartmouth Physics Department. They put him in touch with this guy, Edward Frost, who was not a radiologist. There were no radiologists back then. He was a physics and astronomy professor at Dartmouth. And Landgill said, look, if I give you the plates, can you set up the tubes? And he said, yes. Now we just need a patient. So Edwin Frost contacted his brother, Gilman Frost, who was at the medical school. Gilman found young Eddie McCarthy, 14 years old, who had fallen through the ice skating. This is Nurse Frost, Gilman's wife. And this is the very first clinical X-ray ever taken. They tell me that there's an ulna fracture here. I think it's hard to see. I think it's there. This was a 20-minute exposure, and you could see when you expose it too long, the images turn black. Landgill didn't read Röntgen's article well enough because it should have been a 15-minute exposure, but that's why it came out that way. But what's very interesting is that this wasn't only used for clinical purposes. Back in 1898, if you were a cool person like the Tsar and Tsarina of Russia, this is what you did. You got calling cards made with your hand on them. This was shot at the Winter Palace in St. Petersburg, and they invited Dr. Horn, H.H. Horn, to make what they called photographs of the hand. And this is very typical. People would put all their jewelry on so you could figure out whose hand it was. And everything I read had the same anecdote that the X-ray apparatus overloaded the palace's electrical supply. People literally lined up to see these X-rays. This is 1896. Edison, Thomas Edison, set up this, in 1896, this National Electrical Exposition. And here's people lining up to look at themselves or their body parts with these handheld fluoroscopes. Matter of fact, this is a picture in Edison's lab. This is Thomas Edison himself. This is Edison's assistant, Clarence Daly. And if we take a close look at this, we can see exactly what's going on here. There's the X-ray tube in the box. Edison's holding a handheld fluoroscope, and Edison is looking at the bones of Daly's hand with this handheld fluoroscope. Edison spent a lot of time doing this. Indeed, Edison spent so much time doing this that Daly ended up dying from radiation exposure and became the first martyr in the early days of radiology research. Okay, so now let's talk about the indications. Why would you get hand films? Well, we think about trauma, but not so much falling. As we're going to talk in great detail on the next lecture, when you fall on an outstretched hand, it's your wrist that takes the hit, not so much the hand. So usually you're going to be ordering wrist radiographs. You're going to order hand radiographs when something really involves the fingers. And again, the hands are out there. They're very exposed, so they're exposed to things like bites. And the thing about bites as a problem is bites can lead to infections. You can get deep-seated infections, particularly from human bites. I mean, we'd like to think that people don't go around biting each other, but they do get into fist fights. And when somebody punches somebody in the mouth, the teeth actually cut through the skin and the knuckles, and you can get a deep-seated infection in the bone. We call that a fight bite. Certainly animals can bite people. We particularly worry about cats or little kittens because their teeth are brittle and can actually break off, and you get a little tooth foreign body in the fingers. Dog bites are certainly a problem, too. Here's a case that I recently had of somebody got bit by a dog. This is 3 weeks later, and I was very bothered by this radiograph. If we take a good look at this thumb proximal phalanx, the fracture's not healing. That's a bad sign. At 3 weeks, I shouldn't see the fracture so well. And if I look real closely, I can actually see the lucency around the puncture site, and we were basically raised the concern that this was infection, osteomyelitis, due to this dog bite. One reason that we often get hand radiographs is to look for foreign bodies. And I have a whole collection of foreign bodies that people got into their hands. This is an example of a thumb versus nail gun. This is a laceration. This is a thumb versus a kitchen knife. And then, of course, we have these, the amputations. This was a hand versus table saw. This one was particularly gory because not only did I have to look at this, but I actually looked at this. The fingers, you can see it's still in the work glove. This should never happen. I have way too many of these in my collection, and I think that everybody should get one of these, which is called a saw stop. And this is the amazing device. So when the saw touches the saw, it disappears. I actually happen to have one of these saw stops here. If you want to take a look at it, this one is one that hit something and got locked in place. You can't buy this on your home table saw because it would raise the price too much. It's like saying, well, I'm not going to sell your car with airbags, so it's going to raise the price too much. No, this is mandated. I don't want to see any more of these. I got all kinds of one. Here's one with the table saw. I just got the guy right in the thumb. And of course, the thing that we all know about here in Madison is snow blowers. And the first snow of every winter, I'm guaranteed to have a case like this. This is hand versus snow blower. And this is a real big problem. In fact, according to the U.S. Consumer Product Safety Commission, each year snow throwers cause 6,000 ER visits and 600 finger amputations. The bottom line is when you're dealing with your snow blower, you don't want to put your hand anywhere near this part of the snowblower. That's not the business end. You want to be standing back there. I'm terrified of my snowblower. Back in the summer, we talked about arthritis. And just to review it, arthritis is a very good reason to image the entire hand. Because certainly you're going to image whatever joint is painful, but you also want to get the hand. Because the most common characteristics, distribution, erosions, osteophytes, all things we talked about back in the summer for all the most common arthropathies. Osteoarthritis, rheumatoid arthritis, erosive OA, gout, CPPD, psoriatic arthritis, they are all very well reflected in the hands. Let me just briefly review arthritis with you. Here's somebody, we got bilateral hands, and what we can see is joint space narrowing, specifically the DIP and PIP joints and the base of the thumb, the carpal metacarpal and STT joint. It's sparing the MCPs, it's sparing the rest of the wrist, and this is a bone-producing disease. We have subcortical sclerosis, we have osteophytes. What disease is this? Perfect, osteoarthritis, very good. The most common arthropathy that's out there. This is kind of a similar looking appearance. You still see the joint space narrowing. It's involving the interphalangeal joints. It looks just like OA. It's sparing the carpus, the wrist, just like OA. But if we look real closely, we get these funny looking erosions here that we call gull wing deformities. And what do we call this disease? Exactly. It involves the DIPs, it's symmetric, it involves older women, and that's erosive OA. Now compare that to this disease here, which looks completely different. What we see is joint space narrowing, but now it's the metacarpal phalangeal joints, the metacarpal phalangeal joints and the wrist, all the intercarpal joints. This is very much unlike OA. It's sparing the IP joints, very much unlike OA, and we see subluxations at the MCPs with ulnar deviation. What disease is this? Right, perfect. This is rheumatoid arthritis with mirror image symmetry. This might be a little more harder case. We have the distribution's going to help us. It's kind of a random distribution. Not all the IP joints are involved. Not all the MCPs are involved. And if we look real closely there, what do we call that? Oh, good. Yeah, fine. Rat bite. Yes, exactly. That's a rat. That's an erosion. Right. Rat bite erosion. Perfect. Perfect. Sharp margins, overhanging edges. So what do we call this? Exactly. This is gout. Less common in the hands and the toes, but we can sometimes see it in the hands as well. Now we're getting into harder cases. This one, we've narrowed all the MCPs, very much unlike OA, more like RA in distribution. But if we look at the wrist, we see chondral calcinosis, this calcification of the triangular fibrocartilage, of the lunotriquetral joint. What do we call this disease? Excellent. This is CPPD, otherwise known as pseudo-gout. Calcium pyrophosphate deposition disease. Again, hands are the whole key to this lecture. And then you got this crazy case that has a funny distribution. It's kind of a random distribution. You got a really ugly looking joint there. You got a funny looking joint there. Matter of fact, what do we call this type of joint? Well, sausage would be a swollen finger. This is a pencil and cup erosion. Perfect. Like a pencil in a cup. So what disease is this? Excellent. Sorry, you're ahead of the medical students. So these are the main reasons we get hand things, so there's something specifically at the hand. Now, certainly masses, if you're going to have a mass in the hand, we're usually going to work it up with an MRI or with ultrasound, but we should always start with the radiographs. That's the key message to every one of my lectures. Start with the radiographs, because it helps you see the mass size and helps with planning other studies. I mean, here's a patient with this big mass that's been growing off their finger for years. We get the radiographs. It doesn't show us too much, but it does show us there's no bone involvement. It's not a bony mass. When we get the MRI, we can see this big mass. It's very bright on T2, like a lot of things are. This ends up being, when they cut into it, it had a kind of a fatty appearance, which was interesting. Matter of fact, the surgeons came to me and said, I think this is a fatty mass, like a lipoma. And I said, well, I don't think so, because it didn't look at all like fat on a T2 weighted image. I think that this is a nerve sheath tumor. And that's ended up with it being a schwannoma, a nerve sheath tumor. But again, the point is we start with the radiographs to see how much bone involvement is and decide what the correct study is. When people just have pain for no good reason, it usually don't find too much on the radiographs. One thing, a lot of people have carpal tunnel syndrome. You guys know all about carpal tunnel syndrome. I expect the radiographs to show nothing. But the surgeons are going to order hand or wrist radiographs anyway, mostly because if they're going to do an operation, they don't want to have any surprises. And it took me a long time to find this case, but here's a case, PA view of the wrist looks pretty good. On a lateral view, we look closely, that's not normal. There's this little calcification in the carpal tunnel. This little calcification, whatever it is causing the carpal tunnel syndrome. We actually had radiographs from 8 years earlier that showed that wasn't there. So this was kind of an unexpected finding. So now the surgeon knows to go in and not just release the transcarpal ligament, but actually address this calcification. So I think anytime before anybody operates, even if you're not expecting to find something, let's get the radiographs, make sure that there's no surprises. If you're dealing with pediatric patients, at some point you're going to want to get a bone age study. And these are very interesting. At birth, many of the bones are unossified. The carpal bones, for example, notice the wrist, that's the exact opposite of what we need. No, I like the lights on more. There's a whole new system up here. So notice at birth, none of the wrist bones are ossified. This is 0 years, 0 months. And also, we don't see the epiphyses at the ends of the bones being ossified. So the radius, the ulna, the metacarpals, the phalanges, we see the shafts, but not the epiphyses. And with aging, these bones gradually start to ossify. But they ossify at very specific ages. So for example, at 1 year, we already expect to see 2 of the carpal bones forming, and we can start seeing a little epiphysis at the proximal end of that phalanx. And then as the patient continues to age, we see more and more ossification. Here we see now a 3rd carpal bone is formed. We see the epiphysis at the end of the radius. We see more epiphyses at the end of the phalanges. And we can basically get these bone ages, and we expect to see the patients become more and more mature as time develops. So here we are at 10 years old, and you can kind of see all the bones are here, but they still have ununited growth plates. And we get these hand radiographs to compare the patient's skeletal age, their bone age, to their chronologic age. You don't do this a lot, but if you've got kids who you think are skeletally mature or skeletally delayed, or they have some weird syndrome, you may want to get this study. The interesting thing about bone ages is that we take the radiograph and we compare that to this book by Grulich and Pyle. And this may be the most famous book in all of radiology. We've got one of these in all our reading rooms. The first edition of this book came out in 1950. The second edition came out in 1959, and since then, nothing. This work has not been reproduced since 1959. Basically, in my lifetime, this work has not been reproduced. Because this was done what Grulich and Pyle did is they took middle-class white kids in Cleveland in the 1930s, and they just radiographed all of their hands over serial years. You can't do that anymore. There's no way to repeat this study. But we still use this because this is the gold standard that we have. Now, whether middle-class white kids in Cleveland apply to your population, I can't tell you, but this is the only book that we have. And as the child starts getting older, we'll see that the growth plates get narrower and narrower, and they start getting more mature. Oh, it's interesting. The bone age is always based upon the left hand. That's the standard. Grulich and Pyle felt that the left hand is going to be less traumatized than the right hand, so it's probably normal. If you notice all those lacerations and amputations, they were all of the left hand. Because if you think about it, if you're holding the saw with your right hand, you're going to cut off your left fingers. And then once you get beyond 14, 15, you start seeing the bones becoming very mature, and by the time you get to be 18, 19 years old, you're basically an adult. All the growth centers have fused. Okay, so now let's talk about some terminology in the hand. And we're going to talk about the hand is different than the wrist. So if you're getting hand imaging, we really need to include all of this much. Hand imaging includes the distal radius and ulna, all 8 of the carpal bones, all 5 of the metacarpals, all 14 of the phalanges, and all the joints. And the joints are really where the action is. So we're going to look at a lot of joints, the distal radial ulnar joint, the radial carpal joint, the mid-carpal joint, the carpal metacarpal joints, as well as the metacarpal phalangeal joints, and the interphalangeal joints. In the thumb, there's only one, so we call that the IP joint or the interphalangeal joints. In the fingers, there are 2. So we talk about the PIP, the proximal interphalangeal joints, and the DIP, the distal interphalangeal joints. And certainly it's my job as a radiologist to look at all these things if you're really interested in the entire hand. However, if you're really only interested in the wrist, we'd rather just get a wrist radiograph. Because first of all, with a wrist radiograph, there's less stuff to look at. I'm only looking at this much stuff. So it allows me to focus my attention on just what's important, and it lets us focus the X-ray beam on what's important, and focus the X-ray beam on the area of interest, and that's really crucial. Because the way we do a hand and a wrist with the X-ray beam is very different. With the hand radiograph, the X-ray beam is centered over the 3rd metacarpal head. So the X-ray beam is going to be centered right like that to get everything in the field of view. But with a wrist radiograph, the X-ray beam is centered not on the metacarpal head, but on the wrist, actually at the capitate. So different centering. Does that make a difference? Well, sometimes it does. Here's a patient came into the ER, has a PA view of the hand, it's negative. Lateral view of the hand is negative. PA view of the wrist is negative. Lateral view of the wrist. Oh, if we look real closely, there's a little fracture there on the back of the radius. We can't see that fracture on the hand view. Even if we magnify up on that, we can't see it because this is not centered over the wrist. It's centered over the hand. A lot of times when you have a patient come with hand pain and wrist pain, you'll think, well, I'll get the hand because the wrist is included on it. That may not be a great choice because it's not giving the optimal imaging. What I see a lot is patients have wrist pain and elbow pain. So they say, oh, I'm going to get a forearm radiograph because that includes the wrist and the elbow. That's actually false economy because a forearm doesn't really show you the wrist or the elbow very well. So you should always get images centered on the body part that you're interested in. Let's talk about a little more terminology, medial versus lateral. The very first lecture I gave you about language of fractures, we talked about medial and lateral. I told you medial means towards the middle, lateral is towards the side. I even showed you this radiograph of the tibia, where the tibia is a medial structure, the fibula is a lateral structure. You guys know all that. But in the hand and wrist, these terms are ambiguous, so we don't use these terms. For example, is your thumb a medial structure or a lateral structure? This question has actually plagued mankind for millennia. This is the tomb of Horeb. He's the pharaoh after Tutankhamun and before Ramesses. And if we look at this guy's hands right here, well, here the thumb is medial, here the thumb is lateral. Okay, that's kind of confusing. Matter of fact, this is Ramesses himself. And if we look at Ramesses' hands, here's the thumb is medial, here the thumb is lateral. Clearly, it depends upon how you hold your hands, whether they're supinated palm up or pronated palm down. Matter of fact, I think the best example of this that I could find is these guys, the muffler men. Anybody know about these guys? This was created in the 1960s by the International Fiberglass Company in Venice, California. And these things are all over California. They're 23 feet tall. They're designed to advertise mufflers. Here's one in Escondido, California. Here's one in San Jose, California. Here's one in North Carolina that they changed to look like Paul Bunyan. But what I wanted to show you was this guy here who's not holding anything. And he's showing you how you hold your hands. When your hand is palm up, which we call supinated, I remember this goes supinated like you're holding a bowl of soup, supinated, then your thumb is lateral. But when your hand is palm down, when it's pronated, your thumb is medial. So clearly, medial and lateral are not the right terms to talk about the hand. Whenever we talk about the hand, we talk about radial or ulnar instead. So this would be the radial side of the hand. This would be the ulnar side of the hand. And this isn't me just being nitpicky. This is the official terminology according to the American Society for Surgery of the Hand. Here's this book that they published all these terminologies in. So when you talk about hands, we're always going to talk about radial and ulnar side. But now let's talk about fingers. It's very nice when my technologist puts an arrow on my image showing me my site of pain. But when my technologist does this, it doesn't really help me very much. What's really nice is when you guys give me a history as to which finger hurts. But I want you to indicate that finger not by number, but by name. Let's try an experiment right now. I want everybody to hold up their first finger. Perfect. So about half of you are holding up your index finger, and half of you are holding up your thumb. Unless you're from this family in which you hold up your long finger. My point is that finger numbering is confusing. It's confusing for the people ordering the radiographs, and it's even confusing for the people taking the radiographs. Here's an amazing example. These are two fingers. One's on the right side, one's on the left side. Same patient, same day, same technologist shot both these hands. Here they're calling the thumb finger number one. Here they're calling the index finger number one. They both can't be right. Here's another example, calling the index finger number one. It's too confusing. Fingers have names, not numbers. I want to encourage you to use their names. This is, again, the official names for the American Society for Surgery of the Hand. Their names are thumb, index, long, ring, and small fingers. If you want to call the long finger the middle finger, that's okay too. If you want to call the small finger the pinky, I guess that's okay. That's not the official name, but I know what you're talking about. The point is, if you talk about names not rather than numbers, nobody's confused. Now let's talk about how we shoot these radiographs. And one thing I'm emphasizing in earlier lectures and in these lectures is that you need to have multiple views. Here's a nice example. Here's a PA view. I think I might have even showed you this example. PA view. They're telling us they're worried about the PIP joint of the index finger. Looks pretty good on that view. Here's the oblique view. Maybe it's a little bit offset. Oh, here's the lateral view. This joint is frankly dislocated. It's hard to even imagine how the lateral view corresponds to the other views, yet we see this all the time. So let's first focus on this view. Notice I'm calling this a PA view. PA view, not an AP view. PA and AP are not the same thing. If you remember back when we talked about chest, I told you all about the difference between the PA and the AP. That the PA is the standard view, with the X-ray tube horizontally oriented, the patient standing up, shot posterior to anterior. PA view, that's the standard way we shoot chest radiographs. As opposed to the AP view, which is done portably with a vertically oriented X-ray beam shot anterior to posterior AP. So just like in the chest, the PA is the standard view. Just like in the hand, the PA is the standard view. So here's Marty. We're going to watch Marty grow up through all these lectures. So Marty's going to show us how we shoot hand radiographs. It has to be at a very specific position. We shoot it with the elbow at shoulder height, elbow at 90 degrees. This is the technologist's job. But this is a tricky position to achieve. Normally what we have to do is we have to sit the patient in a low chair. We may have to do something to raise the X-ray cassette up. We'll give the patient something to shield them from X-ray radiation to the genitals. And here's what it looks like when we shine an X-ray beam on the hand, and it's posterior to anterior, PA view. And the X-ray beam is centered over that third metacarpal head. So that's the PA view. Again, we want multiple views. Second view we like to get is the lateral view. And it really needs to be a fan finger lateral like this. And we have this special wedge that we use to allow the patient to fan out their fingers. This is what happens if you don't fan the fingers. This is an outside radiograph where all the fingers were overlapping. I can't see anything. Where the patient came back to us, we got a good UW radiograph, and now you can see the fingers are well fanned. I can see all the individual phalanges. So again, here's the lateral view. The lateral view I like. It's a good secondary view of the phalanges, of the DIPs, the PIPs. The problem with the lateral view is all of the metacarpals overlap. So it's not a good second view for the metacarpals. Here, for example, is a patient, PA view. They even tell me, this is the technologist's arrow, that they're worried about the ulnar side of the hand. I don't see anything on the PA view. Lateral view, there's too much overlap. I see some soft tissue swelling, but I don't see a fracture. So we go back and get the oblique view, the third view, and now the oblique view very nicely shows this non-displaced fracture. You always need multiple views. The point is, the lateral view is not your second view of the metacarpals. The oblique view is. The oblique view we also shoot with one of these wedges, so we can get this nice oblique view. And by the way, these wedges are not very expensive. Here at the UW, all of our technologists use them. If you happen to be working at some other clinic and they're not giving you good images, point them to this lecture, point them to this website. You can buy one of these wedges for all of $10, and it makes a huge difference in shooting your radiographs. So I really like the oblique view as a second view of the metacarpals. Here's another example of, if we look real closely there, a little fracture, little chip fracture at the base of the metacarpal shows up only on that oblique view. This oblique view also gives me additional views of the phalanges and the carpal bones. So why not get all three views? It doesn't make any sense not to get all three views. Does getting less than 3 views of the hand save radiation? Not really. If you remember one of the first lectures, I talked about a chest, PA and lateral is 0.6 millisieverts, about 1 week's worth of background radiation, almost nothing. A 3 view of the hand is 0.01 millisieverts, like 1 day worth of background radiation on the Earth. It's literally no radiation. So we don't really save any radiation by getting 1 view rather than 3 views. Does it save money? Not very much. The UW is not very forthcoming with these numbers. I really had to dig to get them. But as far as I can tell, if you order a hand, whether you order a 1-view hand or a 2-view hand, they charge the patient $113, charge the insurance company $113. So notice, there's no reason to get a 1-view hand. The 2 view costs the same price. You order 1 view, I'm going to give you the 2nd view for free. So always get 2 views, but I really think you need 3 views. The 3 view only brings the price up to $142, and I think that 3rd view, between the PA, the oblique, and the lateral view, is very crucial for looking at all of these. One thing I want you guys to keep in mind, though, is you don't have to order hand films. You can order finger films. If you're interested in only 1 finger, you should get a radiograph of just that finger. Because, first of all, it costs less than a hand. Whether you get 1 view, 2 view, or 3 views of the finger, the price is $106. This might be the cheapest thing in the whole radiology department. It costs $36 less than a 3-view hand. And the nice thing about getting a dedicated finger view is we can actually bend the other fingers out of the way and get perfect lateral views of that finger. We tend to use a non-radial opaque object like a tongue blade to extend the finger, and then you get a beautiful X-ray radiograph centered right on the finger that you're interested in. So by all means, if you're really interested in the phalanges, get finger views. If you're really interested in the metacarpals, that's where you get hand views. And if you're interested in the wrist, you get wrist views, which we'll talk about on Friday. I just want to talk a little bit about digital imaging. This is some interesting graphs that I found. This is digital camera sales in blue, from 0 in 1995 to basically off the chart in the year 2005, 2010. This is film camera sales. Basically, by 2010, film camera sales stopped. This is the graph showing film roll sales and how precipitously it fell off from 1995 to 2010. And that's why Kodak, after 130 years, declared bankruptcy in 2012 because they couldn't sell film anymore. So this caused a big revolution, not only in your own little camera, but also in digital radiology. So just a little terminology. Right now, we have 2 ways of shooting digital images. One's called CR, which is computed radiography, and the other is called DR, which is digital radiography. They're very similar, and you're not going to order one or the other. Everything you're going to get is digital. But just so you understand it, the CR is very similar to old-fashioned film radiography. The technologist still places a cassette under the patient, and the cassette contains what we call a stimulable phosphor plate rather than a piece of X-ray film. We don't use X-ray film anymore. And then we run the cassette through an image processor, an IIP, which is a laser camera rather than a dark room. We don't have dark rooms and chemicals anymore. It's all done digitally. And this is very nice because we could use basically the same X-ray room and just replace the plates, and we do bones and abdomens and portables. But we're also very quickly moving to something called direct radiology, radiography, DR. And this is more similar to your modern digital cameras, in which the image is captured directly into an image detector. There is no separate cassette. And we use these for these upright chests. If you remember, I talked about the dual energy chest, where they shoot 2 images right after each other. That uses that DR technology. You can kind of tell when you're looking at the room if it's a CR or DR room. If it's a CR room, we still have these cassettes everywhere, but these cassettes contain the phosphor plates rather than film. This is the IIP, the image plate reader, that after they shoot the image, they run the plate in there, they run the cassette in there, it processes the plate, it wipes the plate clean, and we get the digital image. This is our X-ray room. This is our CR room. It's literally the same room we've been using forever that we used to use for film, because you don't have to change anything in here. Same X-ray tube, same cassette holder under the X-ray table, same cassette holder in the upright unit, and that's why a lot of people go to CR first, because it's a less expensive investment. You don't have to change the room over, just the plates. This room looks very similar, but this is now a DR room. Has an X-ray tube, but the DR detector is built in the table. We're not moving plates back and forth. Similarly, the DR detector is built into the upright unit. The main advantages of going to digital almost speak for themselves. No more lost films. Everything's on the PACS, the picture archiving and communication system. Images are instantly available to everybody. You can look at it. Clinics anywhere can look at it. I can look at it all simultaneously. We're looking at images over the internet or over the PACS, not pieces of film. It makes it very easy to compare to old studies. I can put them side by side. And the nice thing about it is we can apply digital image processing. Now, some of this digital imaging processing is done at the workstation by the reader, by me and by you. And it would behoove you, when you're learning how to use the PACS, to learn some of the tricks, like magnification. I always magnify up on my images because my eyes are getting old and I like to see things better. We can control the window and level, make things darker and lighter. You can do all those things just using the mouse on your own workstation. It's easy to do. But then there's other imaging processing that only can be applied by the technologist at the IIP, and that's what we call edge enhancement. And this is a little subtle, but it's important for what I do. We like edge enhancement because it enhances the details of the cortex, the trabeculi, and the fracture margins. So here's edge enhancement. This is our standard processing, and look how crisply you can see the fracture and even the trabeculi. The problem with doing this edge enhancement, which we do almost all the time, is that it causes a black line artifact around metal. So here's that same patient. They fixed the fracture with 2 screws, and I don't know if you can see, there's kind of like a black halo around the screws. That's what it looks like when hardware is getting loose. So I need to distinguish, is this really getting loose, or is this just a processing artifact? So when my technologists see metal, what they'll do is they'll run this. This is a non-edge enhanced. This is a softer image. Notice it looks not as crisp as this one, but it makes the black line artifact go away. So sometimes you may see those images. I can't control that, but I can make the technologist reprocess it. If you can't see this, here's an example I found on Wikipedia. Here's what edge enhancement looks like. Here's what non-edge enhancement looks like. So we like edge enhancement, except when it causes metal artifacts. Okay, enough technical stuff. Let's talk about fractures. We're going to focus on the fingers. I'm going to build this finger model. This is the metacarpal head. This is the proximal phalanx, middle phalanx, and distal phalanx. You have to understand there's some tendons we need to worry about. There's the extensor digitorum tendon, which extends the fingers, and there's a flexor digitorum tendon that flexes the fingers. Now, of course, I can't see these tendons on radiographs. I can see them very nicely in MRI. And what you can see here is there's the flexor digitorum tendon, here's the extensor digitorum tendon that we can look at an MRI or even with ultrasound. So the first fracture we're going to talk about occurs when your distal phalanx gets struck by something, like a baseball, and it causes the distal phalanx to go, that DIP joint, to go into forced flexion. And we call this a mallet finger, also known as a baseball finger. And what happens, one of 2 things can happen when you have this forced flexion. One is that you could just tear the extensor tendon, in which case I won't see a fracture radiographically. But the other thing is you can actually have an avulsion fracture of the dorsal base of the distal phalanx. And that's what I'm going to see on a radiograph. Whichever one of these mechanisms you have, the patient's going to be unable to actively extend their DIP joint. So here's what they look like clinically. They come in with the DIP joint bent. You can straighten it passively. They can't straighten it actively because the extensor tendon is not attached to the distal phalanx. You're going to get a radiograph, and if it's a fracture, the radiograph looks like this, the mallet finger, with a fracture off the dorsal base of the distal phalanx. These you're going to see all the time. They're not a big deal. You don't have to send this to ortho clinic. You can if you want, but normally we just treat them with a little splint like this to hold it straight. Here's 3 weeks later. Patients in the splint, you can actually see the splint. Fracture's looking a little bit better. After 8 weeks, can barely even see the fracture. Fracture's healed. Mallet finger. We see this all the time. I had to question this term mallet finger. Everywhere I looked it up, it said, oh, it's called a mallet finger because it looks like a mallet. Really? This looks like a mallet? So I Googled the term mallet, and I got something that looks like this, or like this, with something sticking out of both sides. That doesn't look anything like this. So I went through Google to find something that looks like this, and it turns out what this actually looks like is this. This is a pry bar. So really, I think this should be called pry bar finger, not mallet finger, but we're going to have a lot of misnomers, but mallet finger is the official name for this. Okay, so this is the lateral view. I told you that there's one extensor digitorum tendon, that's true, but on the flexor side, there's actually 2 tendons. There's a flexor digitorum superficialis. Superficialis means on the surface. And that one goes across the PIP joint. But deep to that is the flexor digitorum profundus. Profundus meaning deep. And that one goes to the DIP joint. And the reason why I'm showing you that is these mallet fingers can get more complicated. This is your basic mallet finger in which you would disrupt the DIP, the tendon going to the DIP, just like that. But sometimes when this happens, the flexor digitorum profundus slips around the PIP joint like this, and the PIP joint goes into hyperextension like this. And if you see this configuration, we call this a swan neck deformity, because it looks like the swan's neck. A swan's neck is flexed distally and extended proximally. So here's an example of a swan neck deformity, where the patient has the DIP inflection and the PIP joint in hyperextension. Swan neck deformity. This is due to trauma. This is one I stole off the internet because the most common cause of this is not trauma, but rheumatoid arthritis, causing tendon and joint disruption. Now, this is where it gets a little confusing. If your DIP is in flexion and your PIP is in hyperextension, that's a swan neck deformity. You can have the exact opposite, in which now the PIP is in flexion and the DIP is in hyperextension, and this we call a boutonniere deformity. Here's what a boutonniere deformity looks like on a radiograph. DIP in hyperextension, PIP in flexion, boutonniere deformity. Boutonniere is French for buttonhole, because I guess this PIP joint looks like a button going through a buttonhole. Again, the case that I have is due to trauma, but here's another case that I stole off the internet to emphasize that rheumatoid arthritis is the most common cause of this. And I love this picture here, because if you look at this, they have a boutonniere deformity of their small finger, and they have a swan neck deformity of their ring finger, both of them in a patient with rheumatoid arthritis. Here's an example of a patient, young woman, 24 years old, rheumatoid arthritis. The PA views are negative. But here's the lateral views, and we look at the lateral view right there and there. She's got boutonniere deformities of both fingers. And this is pointing out, first of all, the importance of multiple views, as well as the importance of a good fan finger lateral. Oh, I just wanted to show you this picture. When I was researching this lecture, I found this picture here. This is the Three Graces, painted in 1638 by Paul Rubens at the very end of his life. The model for this was his young wife, Helena, who was 23 years old. Matter of fact, she's the model for all three of the Graces. But if we look at this hand right there, oh my God, look at this terrible hand. PIP inflection, DIP in hyperextension. This is a boutonniere deformity, and it's speculated that either Helena had rheumatoid arthritis, or actually Rubens himself probably had rheumatoid arthritis. He could barely hold the brush. He basically strapped the brush to his hand, and he was kind of showing his own hands in this painting. Okay, more fractures. This is a fracture I see every weekend. This is when you have the dangerous combination of a college student and alcohol and a brick wall. And the student will make a fist with their hand and punch the brick wall, fracturing the fifth metacarpal neck, and we call this a boxer's fracture. Here's what it looks like radiographically, this fracture, this angulated fracture of the fifth metacarpal neck. Actually, this is a misnomer because boxers don't get this fracture. Boxers know how to punch. This is better called barroom brawler's fracture. But we see these I literally see these every weekend here on campus. Here's the PA view. The oblique view is very nice because it actually shows the fracture best. If we take a close look at that, we see not only does this patient have a boxer's fracture, they actually have an old healed fracture of their fourth metacarpal, which leads to one of my axioms that trauma is not evenly distributed in the population. People who punch walls on Friday nights have done so in the past. We like to get the lateral view as well. I told you the lateral view, it's hard to see the metacarpals, but in this particular case, you can actually measure the degree of angulation of this fifth metacarpal fracture because it's sticking forward. These tend to all get cast. They get this weird cast where the small and ring finger MCP joints are held in 90 degrees of flexion, casted like this, and this is what you need to do to allow this fracture to heal properly. Okay, now we're going to move to the thumb. And the thumb is very important. While these mallet fingers and maybe even the boxer's fracture, if you're comfortable with them, I'm more than happy to have you guys treat in clinic. Anytime you get the thumb involved, you got to send that to hand clinic. I don't mess around with thumb fractures. So the first one I'm going to talk about is what's called the gamekeeper's thumb. This was described by Dr. Campbell, who was doing his work in Bridge of Erne, Scotland. Now, I don't know anything about Scotland, so I Googled Scotland. And Bridge of Erne is way, way up there, kind of in the middle of nowhere, which kind of explains how Campbell did his work examining 24 gamekeepers in this one little village of Bridge of Erne, Scotland. I don't think you could find 24 gamekeepers in the entire United States. What he found, though, was very interesting. Of these 24 gamekeepers, 20 of them, 80%, had the same exact laxity of the thumb. It was involving the metacarpal phalangeal joint on the ulnar side. And they all had the same findings. So let's now build a model of the thumb. This is going to be a PA view. There's the metacarpal, proximal phalanx, distal phalanx. And what we're interested in now is the ligaments that go around the metacarpal phalangeal joint. And again, they're not medial and lateral. There's a radial-sided collateral ligament and an ulnar-sided collateral ligament. Here's a patient that I had, not a gamekeeper, but a patient who had this injury. And if we get a straight PA view, they look pretty good. This is a patient who had fallen a year earlier and presented with decreased pinch strength. When he tried to pinch something, he had no strength. What's going on here? Well, what's going on is he disrupted his ulnar collateral ligament. If you tear the ulnar collateral ligament, you can just imagine if you put some stress on this joint, the whole joint's going to fall apart. Well, it's pretty dramatic when I show you this for PowerPoint, and it's equally dramatic when you put some stress on this guy's thumb and the whole joint falls apart. So he had actually torn his ulnar collateral ligament. There's a couple of ways that you typically injure your ulnar collateral ligament of the thumb. One is from acute trauma or fall, particularly skiing. This is also called skier's thumb. And it's particularly caused when you fall while skiing and you're holding the ski pole, and you fall on the ski pole just like that, tearing your ulnar collateral ligament, or actually causing an avulsion fracture of the ulnar base of the thumb proximal phalanx. So if any of you are skiers and you plan upon falling while you're skiing, as you're falling, let go of the pole. You don't want to fall with the pole on your underneath your thumb, because that's how you get this gamekeeper's thumb. Either tear the ulnar collateral ligament or actually get a fracture. And here's a patient that we had with this fracture, this little fracture off the ulnar side of the base of the thumb proximal phalanx. Here's this PA view of the thumb. Here we can see it very nicely on the hand, zooming up, showing the fracture of the base of the thumb. Don't confuse that with this. That's not a fracture. That's the normal sesamoid bone at the thumb. The other way to injure your thumb metacarpal phalangeal joint ulnar collateral ligament is with repetitive stress on the ulnar collateral ligament, like if you're a Scottish gamekeeper. Because what a Scottish gamekeeper has to do is get rid of pests, like rabbits. And he has to do it humanely and quickly. So what they do is what's called chinning, in which they grab the bunny's neck and they put this torque on it to dispatch him quickly. And it puts this very big stress on their thumb. And all 20 of the gamekeepers who knew how to do this chinning correctly got this injury. The 4 who didn't do the chinning correctly. The last thing I want to tell you about is Bennett's fracture. And here's my PowerPoint model. And the reason, well, I'll talk about the fracture. And we're going to add in, so we have the distal phalanx, proximal phalanx, metacarpal, and the trapezium. Remember, the trapezium is the carpal bone the thumb articulates with. So, not to confuse the two fractures. This fracture here at the thumb, at the ulnar base of the thumb proximal phalanx, of the phalanx, that's the gamekeeper's fracture. This fracture is very different. This fracture is here at the base of the thumb metacarpal, down here. For you Packers fans, this is the fracture that Clay Matthews has been plagued with all season. This fracture at the metacarpal base. And this is what we call a Bennett fracture. So this was described by Edwin Bennett. He described it back in 1881, which is pretty amazing because that was a whole decade before Roentgen's work. So he had to do all his work just based upon skeletons. It was 14 years before X-rays. It was actually 3 years before George Eastman even created photographic film. So not only did Bennett have to do his work with skeletons, to describe this, you had to make your own woodcut. And this is the original woodcut from Bennett's article showing this fracture at the ulnar base of the thumb metacarpal. And I know this is a long quote, but Bennett wrote very well, so let me tell you what he said. He said, so trivial an injury does this appear to be, so little deformity. I might fairly be asked what importance attached to the correct diagnosis. Seeing the value of movements of the thumb, no injury of it is to be lightly regarded. And this fracture, though it unites readily with almost inappreciable deformity, renders the thumb lame or useless. The hand fails to grasp or lift with certainty any body requiring a wide gape of the thumb. For instance, to lift a tumbler full of water from the table. So this fracture will heal, but if it doesn't heal right, you can't lift a glass of water off the table. Clay Matthews can't destroy people. So we take this fracture very seriously, this Bennett fracture. Because what's going on here with this fracture is we need to keep in mind one tendon. I know there's a lot of tendons in the hand, but this is the one we're worried about here, the APL, the abductor pollicis longus tendon. Pollex just means thumb, and abduct means to draw away. So draw away from midline from the body. So your thumb abductor is what pulls your thumb away from midline. The APL abducts the thumb. So when you have a Bennett fracture, which is an intra-articular fracture of the thumb metacarpal at the ulnar side of the base, the APL is now unopposed. And when the APL fires, you get subluxation of your thumb carpal metacarpal joint. So here's an example. This is an 18-year-old, fell off his scooter, fell onto his thumb, and we can very nicely see the Bennett fracture, the intra-articular fracture to the base of the thumb metacarpal. And when we do ulnar deviation, look what's happening here. Not only can you see the fracture, look at how much that joint is subluxating. That's the problem with this fracture. It's because the APL is being unopposed, is pulling the metacarpal out. We did a CT scan to really show the same finding, but what this requires is a surgical fixation, not a big deal, and this is exactly what Clay Matthews had. Put a couple of pins, put a couple of K-wires through this to hold it in anatomic alignment until it heals. You can then take the pins out, the K-wires out, and everything's healed very nicely. Okay, so to conclude with what to order when, always start with radiographs. You're going to get 3 views of the hand, the PA, the lateral, and the oblique. And that's when you're going to get hand, when you need to see all the bones, all the joints, you're going to get hand films, like for arthritis, for metacarpal fractures, the boxer's fracture. But when you're interested in the fingers, you should just get that finger image. For the mallet, the swan neck, the boutonnieres, you're going to get finger images, the gamekeeper's fracture. What about foreign bodies? Well, radiographs are good for radiopaque foreign bodies. Here's another example of metal. I got a whole collection of these. Anybody have any idea what this is? This is the tip of a ballpoint pen. This is a psych patient who liked to stick things in his hand. And he actually had this metal pen in his hand. But anyway, point is, things that are metal, we just get radiographs. They show up very well. Glass. All glass is radiopaque. So if you have glass foreign bodies in your hand like this, they show up very well. We don't have problems with that. The problem is, what about non-radiopaque foreign bodies, like wood splinters or sea urchin spines? You laugh, but people step on sea urchin spines all the time. You can't see this with radiographs, and you can't see this with CT. You may be able to see them with MR, but you can see them all with ultrasound. And even places that don't do a lot of MSK ultrasound can certainly find these foreign bodies very easily. And here's my final case. This is a little 11-year-old girl, had radiographs, they're negative, because we know we're looking for a wooden splinter. They first sent her for MRI, and here's the MRI through the back of her hand with IV contrast. We can see some enhancement, so we know there's inflammation there, focal area of enhancement. We do a sagittal image. Here's the area of enhancement. Here's the marker. We know right where we're looking, but I just see enhancement. I can't see anything. Whereas when we actually do the ultrasound, what we can see here is that line there, that's the actual splinter. We can identify it beautifully with ultrasound. So different modalities to answer different questions. So what to order when? If you're worried about masses, infections, synovitis, like for rheumatoid arthritis, you're always going to start with radiographs. MRI is the next study for masses, infections, synovitis. If it's masses, infections, synovitis, you're going to want to give intravenous contrast. Contrast is very helpful with synovitis. Normal synovium does not enhance. Vascularized pannus, the vascularized synovitis enhances greatly. Frankly, these studies are kind of advanced. They really should be ordered by the specialist who's going to be treating the patient, like the rheumatologist or the hand surgeon, probably something that we don't have the primary care providers getting involved with. Okay, so if there's any questions, you can raise your disembodied hand. Question?
I'm just wondering if you're able to scan films and put them on the packs?
Yes, so if you're coming from some third world country with films, yes. But we can, but it's a copy, so you're actually losing some resolution. So if you just want to scan something in there to compare to we have something a record, yes. We do that everywhere we have radiology, we have these film scanners. If you actually want me to make an interpretation on the film, I'd rather you bring the film to me so I can see the actual film. Although that's getting harder. We're actually taking our view boxes out of our rooms. So I haven't touched a piece of film in a couple of years at this point. I know some small clinics still use films, but they should really all be at least advancing to the CR technology. It's getting hard to buy film anymore. I mean, people don't make it. It's getting hard to get chemicals in dark rooms. So film is going to be, it's going to have to go away soon. It's just not going to be available anymore. But yes, we can still scan things in. The other thing that's amazing is we used to be required to keep film, physical film, only for 7 years. So anything that's more than 7 years old is gone. We started our packs in 2000. So if a patient has a study since 2000, 14 years ago, I expect to find those images. So everything is still on there. Other questions? Okay, good. So I know we covered a lot of material today. Started out kind of basic, got very advanced at the end. All my lectures, I'm going to try to do that. Start out basic, so I lull you into this false sense of security, and then they'll get more complicated at the end. So if you can at least keep up with the first half of the lecture, that's fine. Everything is going to be on Learn at UW and, with both PDF formats and the actual lectures. The wrist lecture is going to get complicated, so if you could at least get comfortable with the names of the carpal bones, you'll have a big head start on it. So thank you for your attention.